Hello everyone, this is Gina Herrera and I will be presenting the Normal Labor and Birth lecture. This is actually Labor Part 3 and it's labeled the delivery. Okay, so when we're talking about laboring, or the laboring mom, we talk about monitoring and the progress of the monitoring. So what are we monitoring here? We're looking at maternal behaviors. So just as a review, the first stage of labor, we talked about latent, active, and transition. Those are the three phases in that first stage. The second stage would be from transition, which is toward the end, all the way through to the actual delivery. And then the third stage, and we talked about that. That's just a review from last time. You can go back. It's really important for you to know the stages of labor. So first, second, third, and then of course there is a fourth stage, and that's from the delivery of the placenta to the first 4 hours postpartum. So you want to go back and review those. Cervical exams, that's when we assess the dilation, the station, as well as the effacement of the cervix. And that's how we can monitor the progression of labor. We talked about cervical exams or sterile vaginal exams, they're referred to. Again, dilation is the opening of the cervix. It's charted in centimeters. It can go from closed to 10 centimeters. The effacement is the thinning and shortening of the cervix. It's charted in percentages from 0 to 100%. And the station is the descent of the presenting part in relation to the ischial spines, measured in centimeters as well. If the presenting part is at the level of the ischial spines, it is at the 0 station. And the negative numbers are above the spines, positive numbers are below the spines. And again, this is just a review. You should have covered this again, and that was in your Labor 1 lecture. So you can go back to that lecture. You want to go back and review that information if needed. It's a picture of dilation. Again, just kind of like an idea. As you can see, the opening gets larger, the bigger the centimeters, all the way to 10, or completely dilated would be 10 centimeters. Effacement and dilation, here's kind of a diagram of what it looks like. Multigravida, again, gravida means pregnancy, multi means more than one. So this is a patient that's been pregnant more than once. The effacement and dilation will take place concurrently, so it happens a little bit more quicker. A primigravida would be a first-time mom, so effacement is 50% before the labor actually starts, and dilation will take longer because the cervical tissue has not been stretched before. So you can refer to figure 33-43 in your text on page 2299. So you want to go back and look at that. But as you can see these diagrams, you can see where that cervix is nice and thick and it's long, but as the labor progresses, it shortens and it thins out. And that's where we get that, that percentage for that effacement. It effaces or thins out and shortens. A way to express it, you might see it expressed this way in the chart: 5, 90, and plus 1. And what that is 5 centimeters dilated, cervix is 90% effaced, and the station is at a plus 1. So you might see it expressed this way in the chart, and that's what that means. Again, effacement, you can see the left diagram not effaced. You can see how long and thick it is. Okay, and then the effaced one, you can see it shortens all the way almost up to the baby's head. It shortens and it thins out. So as it thins out, it makes it easier for the cervix to open and dilate. And that's all part of progression of labor. We use a speculum exam. A sterile speculum exam may be performed if the patient is preterm. So we don't want to be sticking fingers in there to examine the patient. It's more or less, again, a speculum exam where you go in. It's like a little plastic device. It's got like a little, I call it, it looks like a beak. You put it in and you open up the cervix, open up the vagina to view the cervix. This would be, again, if somebody's preterm, you don't want to stir up anything. So you would look at or visualize if the membranes are ruptured. You can also go in with like a little Q-tip and they dip it in the fluid that might accumulate to check again for specimens if need be. A lot of time if it's pretermer, remember we're looking at that amniotic fluid. If they're leaking amniotic fluid, we can always check to see if the lungs are mature. Sterile speculum is used again to visualize the vagina as well as the cervix. We're checking dilation, presence of fluid, if there's any blood or indicators of infection that can be observed. Just so you know, fetal fibronectin testing is one of those things that we can do. And you know, we talked about the PG testing for the lung maturity. So these are all things that we can use if we're worried about the lung maturity of the newborn. So we assess rupture of membranes, spontaneous rupture of membranes or SROM versus AROM, artificial rupture of membranes. So we look at the time, of course the date, the time, the color, the consistency, if there's any odor. So, you know, again, if the mom is ruptured, say it happens today at 8 o'clock a.m. Well, she has 24 hours from today at 8 o'clock a.m. till tomorrow at 8 o'clock a.m. to deliver this baby. If they go past that 24 hours, there is a higher risk for infection. So the baby doesn't have the fluid around it. That's kind of like a little cushion, and it also protects the baby from any microorganisms. If that membrane opens and ruptures, they can get infected, and it can be very serious for the baby. We want to look at the color of the fluid. Is it clear? Does it have little white particles? If it does, it's usually the cheesy stuff that's on our newborns. We call it Vernex. Sometimes that Vernex is chunky around the baby, and it can show up in the amniotic fluid because the fluid surrounds the baby. If it has little white little specks or particles, that's okay. The problem becomes if it's meconium stain, and that's where the baby will have a bowel movement while inside. And when they do that, that anal sphincter relaxes when the baby is under any type of stress, or, you know, the baby is in fetal distress. They tend to have a bowel movement in utero. Okay, so the fluid can be like a brownish or even a greenish color. So we need to note if that's the case, because it could be thick meconium, you know, pea soup consistency, or it could be thin with chunks of little pieces of fecal matter. But that, again, helps us to prepare for the delivery. We need to make sure that we have the equipment available to suction that baby's lungs out if the baby comes out aspirating the fluid. They can get a serious lung infection if that meconium fluid gets into the lungs. So the color is very important. The consistency, like I said, it could be thin or it could be thicker depending on the meconium. The odor, does it have an odor? If it's a pungent odor, you could have infection already. And that's our moms that they're like, I'm not sure if I broke my water. This happened yesterday or the day before yesterday, and I've been leaking. So I decided to come in. Well, you might have that infectious odor coming from that fluid because they could have an infection already. One thing we do test to see if it is amniotic fluid, because sometimes the patient will come in, they're like, better safe than sorry. I was leaking fluid. I didn't know if it was my bladder that was leaking, because at the end of the pregnancy, when the baby drops down, there's so much pressure. And they're not sure. I mean, it could be urine seeping out. It could be amniotic fluid. Sometimes it's a gush of fluid. Sometimes it's a trickle. It just depends on the patient. But we can test the fluid, and we use nitrazine paper, which is like a litmus paper. That litmus paper will turn dark, dark blue if it is definitely amniotic fluid. If it's not, it stays yellow because it is like a goldish yellow, the litmus paper or the nitrazine paper. Um, so it changes color. Also, they can take a smear of the fluid on a lens, a microscope lens, where they can go in and look on the slide. And what they'll see is the appearance of a ferning pattern. We call it a ferning pattern or ferning, where if you look at the picture on the bottom right hand corner, it looks like fern leaves. And it resembles ferning leaves. And what that tells us is that it is amniotic fluid. So they can check the nitrazine paper to see if that color changes to that dark, dark blue. Or they can take a smear of the fluid on a slide and look at it and see a ferning pattern. That little hook at the top there is that amni hook. If we needed to break the water bag or rupture the membranes artificially, they'll go in and do that with that amni hook. And that little, it looks like a little crochet hook on the end, that little notch is very sharp. It's like a little pin, and what it does is it will snag or puncture the bag and break that water. Okay. We may also have to get mom to kind of bear down and perform a Valsalva type maneuver just to maybe get that fluid to leak and pool in the vaginal canal so that we can get an adequate amount of fluid for testing. How do we manage discomforts of labor? So there's different ones. So non-pharmacologically, we can manage it with comfort measures, supporting the patient, position changes, again at the end, especially when they're really big, it's hard to get comfortable. We may have to put some pillows around mom. Massage, hot or cold compresses, and usually that's to that lower back sacral area sometimes, especially because remember the contractions come from the back and they spread to the front. So sometimes they'll have some seriously bad contractions, and the back is usually something that they complain of, the backache. Hydrotherapy, we can do that. Some hospitals have birthing baths, where they can go into a bathtub and deliver. Sometimes that's with the midwife, more or less. Or we can just put them in the little bathtubs and just kind of give them some hydrotherapy. Teach them rhythmic breathing, and kind of like a Lamaze type breathing, where it's kind of like a pattern of breathing with every contraction to help them. Again, this is management without pharmacologic agents. So this is totally, gearing toward natural childbirth. Hypnotism or visualization. These are things also we use. We always tell mom, pretend like you're on the beach drinking a pina colada and you're not feeling this labor pain. Sometimes just kind of getting their mind off of it, or, trying to distract them usually can be a form, again, to manage the discomfort of labor without drugs. Acupressure or acupuncture, I haven't seen any of that. You can also apply pressure and massage, deep massage to the back, lower sacral area. I've never seen anybody use any type of needles, but I know in different cultures they use different things, and that could be used in another culture. Whoops, go back. So we talk about management. Let's talk about some drugs. Some intravenous medications would be more your sedatives, your hypnotics, your analgesics. Usually this is given in early labor and have very limited times for administration. This is your Stadol and your Phenergan. This is, you give it IV push. Of course, we're not going to give it anytime into the labor, later into the labor, because when that baby comes out, it's going to need some Narcan, because it's not going to be breathing. It may be floppy. It may not be, doing real well there. So we do this at the beginning. Remember, this is not going to take the pain away. It will ease the pain. They won't feel it as intense, but it never really takes the pain away. So it's in limited quantities. Doctors usually don't like to give it often, again, because you're putting that baby in jeopardy as far as their respiratory issues. Um, so usually it's once or twice. It lasts about 45 minutes because it goes straight into the bloodstream, and it's quick acting, but it wears off quickly. So very limited, just something to ease the pain a little bit, but nothing that's going to take it away permanently. Some local anesthetics we can use: paracervical blocks or infiltration of the perineum, and that would be like your local, anesthesia. Commonly used, we use this more or less to suture lacerations, episiotomies at the time of the delivery. Um, we don't see a lot of this used. Um, well, you can see it used with other anesthesia is what I want to say. So, like if mom has an epidural and she's nice and numb, most of the time they're numb enough probably to stitch, but just to make sure that area stays anesthetized, they will put like 2% local with a little 10 cc needle, a syringe with a needle, just to kind of deaden it, just like they would when you go get stitches at the hospital or whatever. So it's called a local anesthetic. Then we have the regional anesthetics. This is your epidural. It takes longer to work, but it lasts longer than a spinal. So it goes into the epidural space. It takes about 20 minutes to get working, but it does last for a long time. And it's usually on a pump. It delivers so many cc's an hour, and mom has a little button she can press. So even if she's pressing it, it's going to have limited dosage. So it will give the max amount. It's on set on the pump already. The spinal is something that goes in, but it works quickly, but it does not provide pain relief for a long period of time. We see a lot of our doctors, not the residents so much, because the residents are learning, so it takes longer, but like they'll go in and do a C-section, say, and they'll do a combination spinal epidural where they'll put the spinal in. It works quickly, so it will work fast, but then they'll take that out and put the epidural in, where when the epidural starts to peak 20 minutes into the spinal's starting to come down, but the epidural is in full swing. So you might see a CSE, a combination spinal and epidural. And it's just the perfect combination because it works fast with the spinal, and then the epidural kicks in by the time the spinal starts kind of wearing off, and it just carries the mom through with pain relief. So she gets instant pain relief, and it lasts longer. Like I said, I've started to say, if the doctors are doing a C-section, and if it's a private doctor, sometimes they just use the spinal because they get in and they get out. They quick. 30, 45 minutes, they're done. So by the time, the patient is done in 40 minutes or whatever, the anesthesia, the spinal can start to wear off, and then we give them pain meds and other stuff in the recovery area. Using the epidural, and usually combination spinal epidural is really good because again, it works fast and the epidural will last longer. So if the doctor's in there, I do Tulane Lakeside, we have Tulane residents, and sometimes when they're teaching the residents, a 45 minute C-section turns into a 2-hour, 2.5-hour C-section. So we need enough anesthesia to keep mom under so that she's comfortable for the procedure. But again, you might see combination. One thing you do need to know with either one of these anesthetics, a spinal or an epidural, it tends to drop the blood pressure. Okay, we anticipate a drop in the blood pressure. So we need to give mom a preload of IV fluids. Even if her blood pressure is stable, we give them like 1,000 milliliter preload. Now, if mom has hypertension or she's got preeclampsia, something else going on with her blood pressure, we don't give the full 1,000. Sometimes we'll start off with 500 and just monitor the blood pressure. But what happens is the anesthesia causes those nerve endings to relax. And how does it do that? Well, it vasodilates the vessels. And when it vasodilates, what happens to the blood pressure? It tends to drop because those vessels open. So to kind of keep mom stable, we give her that preload in anticipation of that drop in blood pressure to kind of normalize or stabilize the blood pressure to keep it adequately at a check level. Because what happens is when that blood pressure drops, that baby's going to have some decrease in oxygen from perfusion from the placenta, and then you'll see that baby in some distress. And usually it's those late decelerations that we see because it's uteroplacental insufficiency. The baby's not getting perfusion. So to avoid that, we anticipate that drop in blood pressure with anesthesia. We give them that preload. And of course, if that preload is not working, we can give them some ephedrine through their IV, and usually anesthesia will push ephedrine because, again, that's a vasoconstricting drug, and it helps to stabilize the blood pressure from that anesthesia dropping the blood pressure. So induction of labor, indications. I'm not sure if this is the right page number because I did change the page number. Let's see. So actually the indications would be on page 2309 instead of 2288 in the text. There is a page number change. I will have this on the handout for you changed, but for right now, just refer to 2309 in the text for indications. Some fetal concerns. Well, there are some fetal concerns because if you're inducing too early, this baby may not be, ready. It could be that the lungs are not developed. Remember, it's not the size of the fetus because you can have an 8-pounder prematurely deliver, and it may not be ready because the lungs are not mature. No matter what, the lungs are the first concern. Also, if you induce someone too early and they're really not ready, or that cervix we say is not ripe, it's green, you can set them up for a C-section. So with a C-section, the fetus can if they're C-sectioned, they're going to get a lot more fluid in the lungs because they don't get that squeeze through the vagina. And when they don't get the squeeze through the vagina to shove or push, expel all that fluid out of the lungs that they may try to aspirate coming out, they can get all of that backed up in the lung area and have some aspiration of amniotic fluid. So there are some fetal concerns. Another thing is if the baby is too big, if you wait too long to induce, the baby may not have that opportunity to deliver from below, and it may have to have a C-section. So, those are all things we have to think about. Maternal concerns, same thing. You don't want to induce mom too early, and worry about her baby having that lung maturity. And if you do too early and that cervix is truly not ripened or ready to do that, to dilate, then you could set her up for a C-section. On the other hand, especially like our diabetic moms that give birth to very large babies, you don't want to wait. You may want to induce them because they're going to have a very large baby. As long as those lungs are mature, that's the big thing. So if mom has a big baby and she hits that 38 week, end of the 37th, beginning of that 38th week mark, it's okay to go ahead and induce her. Just know this, I know OBs follow this rule. It is a rule for them to adhere to. You cannot induce a mom earlier than 39 weeks without a medical indication. So that means she has to have a reason if you're going to do it prior to 39 weeks. So if mom is diabetic and she is having a large baby and we need to induce her, at 38 weeks, that would be a reason right there because the size of the baby. So it's better to try and induce a little earlier, to get her delivered from below as opposed to waiting and then she's prone again to have a C-section. So, maternal concerns are there. Alrighty, and let's see. Talking about induction. So there's natural induction, mechanical induction, or medical induction. Natural induction is when they strip the membranes. Stripping of the membranes. So what is that? That's a vigorous vaginal exam. And that's when they go in and, it's usually after 39 weeks, when they hit 39 weeks, to kind of get things going. The doctor will do that vigorous vaginal exam and roll up the membranes, I guess you could say. So they call it stripping of the membranes, and that in itself can weaken the membranes and cause them to rupture easier. If she ruptures a membrane, she's got to go to the hospital because if she breaks her water, she has 24 hours to deliver. So stripping of the membranes is a natural way to get the induction thing going. Okay, nipple stimulation, well, we talked about this with the contraction stress test. What that does is it causes the uterus to contract because it releases the oxytocin, mom's natural oxytocin in her body. So nipple stimulation is another way. Intercourse. Okay, of course, this has got to be after that preterm period. You don't want to put mom in labor too early. But intercourse, not that they can't have intercourse through the pregnancy, but toward the end, usually it's very uncomfortable. They're very big. So it tends to not happen as much, maybe. But if you do have intercourse toward the end, they say that the actual sperm contains prostaglandin, and prostaglandin is what puts mom, can stir those contractions up as well and causes the uterus to contract with the oxytocin. So the prostaglandin causing the cramping and the contractions from the sperm is what gets things going there. So that's considered a natural form of induction. Mechanical induction is where they have like a Foley balloon catheter placed inside the cervix. So we try to get, if the cervix is opened in any way, shape, or form, we get that balloon in that cervix and we open it up with the balloon. You may have it, you may hear it referred to as the Cook's balloon, and that's what it is. It's a mechanical induction form of induction that uses a Foley balloon to stretch or open the cervix to make it open up and dilate. Medical induction is, sometimes the ones that we're most familiar with, and that's use of misoprostol or Cytotec 25 micrograms. It's a tablet. I know, Ms. Herrera, what are you talking about? You putting a tablet in somebody's vagina? Well, yes, it's actually a tablet. They don't put the whole tablet all at one time. They may break it in pieces, but they put the tablet in, and what that does, it's considered a cervical ripening agent. So it kind of works on the cervix to help it soften and loosen up a little bit to make it more easy for the induction to occur. They usually use that. Now, they can deliver on Cytotec. It can knock them into labor. I have seen moms go into labor with just Cytotec and deliver. It's not very often, but usually it's used in conjunction with oxytocin. So the patient will come in the night before. She'll get the Cytotec tablet placed, usually around 8, 9 o'clock, or even 10 o'clock at night. And then at 5 a.m., they'll start the drip of oxytocin. And the oxytocin will again, cause the major contractions, and they'll increase it as needed. Use of prostaglandin, so that's your Cervidil and your Prepidil gel. Again, prostaglandin, just what they had in that sperm count, is a thing that will soften or ripen the cervix and get the labor possibly going. It's called Cervidil or Prepidil gel. We used to use this more, it was used more than what it's used now. Now it's cost effective more to use the Cytotec. It's, again, it's just a cost effective thing, and it's more commonly used, the Cytotec, over the gels. Refer to table 33-11, the Bishop score on page 2308, and that gives us like a criteria as in order to induce. They usually have to meet a certain criteria with cervical dilation, the effacement, and the station to, I guess you could say, qualify or, get induced. So that is what you want to review. It's called Bishop score. VBAC, vaginal birth after cesarean, or you might hear me say TOLAC, a trial of labor after cesarean. So what is that? What is that? It's a vaginal birth after the patient experiences a C-section, or the trial of labor after the C-section. So mom might have had, her first pregnancy, the baby might have been breech and it just wasn't turning. Okay, so they had to go ahead and do a C-section. So then the second time she becomes pregnant, she's like, I really do want to try and deliver from below. I had to have a C-section with my first pregnancy, but the recovery, and then you got the newborn, and you got, she's like, I really do want to try and do this vaginally. So, if there is an adequate pelvis size, so these are candidates, let's just say that. Previous C-section that has a low transverse incision, low transverse, okay, kind of like that bikini cut. Have an adequate pelvis. No other uterine scars or uterine ruptures. The doctor needs to be near during this induction, and anesthesia near for an emergency C-section. So there's criteria. You can't just go in and just have it done. So like if it's not that the baby was breached, say the baby was a big baby, and this baby might be just as big or a little bit bigger, then it's a no-go. Because we know that mom's pelvis is not going to fit that baby. And they're not going to qualify to be able to do a vaginal birth after a cesarean. So there has to have different criteria. And some doctors don't want to do it at all, because they just feel like it's a risky thing. Why? Because, well, once you make an incision into the uterine wall and mom is having those forceful contractions to have that labor, to deliver below, you can also have a uterine rupture. That incision on that uterine wall from that C-section can open up, and it puts them at risk. It puts the patient at risk, and it definitely puts the baby at risk. So that's why you have to have the doctor present when this is going on we say in-house. And then anesthesia always is near for an emergency, just in case that uterine wall does bust open and ruptures. Okay, so it's a very, very, chancy thing, risky thing, but some doctors are okay with that, and some doctors are like, no way. It just depends. Nursing assessment and interventions. Again, if they're having this, you're going to monitor them very closely. You want to watch, make sure that that baby's not in any kind of fetal distress, for sure. Not that you wouldn't with a labor patient, but even more so, because if something's going on and that uterine wall opens and ruptures, then we got some problems. And also, if it's truly not going to happen, this baby may not tolerate the labor, then of course, intervention wise, we'd have to think about maybe getting the doctor to monitor the patient with you and see that maybe this is not a good thing, that maybe we do need to go and just go ahead and do a C-section. So interventions would be just like you would do for anybody in labor that might have fetal distress. We just turn them to their side, we give them some oxygen, we open up the fluids. If they're on a drip, of course we're going to turn that oxytocin off if that baby's not tolerating it very well. Um, and then plan for the C-section if that's, the plan. Preterm labor or preterm birth, remember that's labor and delivery after the 20th week, but before the end of the 37th week, beginning of the 38th week. That's that cutoff for preterm to term. So that again is something that, the cause is unknown, but it does happen sometimes in 50% of cases. It could be related to an infection, and remember we said it could be even a UTI that can kick this mom into early labor. Usually multiple gestation, if there's more than one baby in that uterus and that uterus is weighed down, it can cause it to start contracting. And again, that uterus is a big muscle. So if it's weighed down and it's stretching those the muscles in that uterine wall, it can cause it to start contracting. Or if there's structural abnormalities of the uterus or cervix, again, if that cervix has been, say mom had cervical issues on a pap smear and they had to take some tissue from the cervix, or, the uterus, if the uterus had some type of, tumors or whatever, and there's some kind of scarring there, that could also lead mom to have an issue with preterm delivery or birth. So it puts her more at risk. Okay, well, let's go back. Before I go to that slide, let me talk to you. So when we talk about preterm labor or preterm birth, there are some drugs we can give. We can give Breathine, which is a sub-Q. You can give up to 3 doses every 20 minutes as needed if the contractions are there. Sometimes the doctor will write parameters. If there's, 3 contractions in a 10-minute window, administer the Breathine 0.25 micrograms sub-Q every 20 minutes. And the big thing with that is we cannot give it if mom's pulse is greater than 120, because you could put her in pulmonary edema. It's contraindicated with a pulse rate greater than 120. So before we even start giving it, we want to get a pulse. Get a baseline pulse of mom. She'll get that first injection. We'll see if it works. If it doesn't work, 20 minutes later, she can get the second. If that doesn't work and her pulse is adequate, she can get a third. If the pulse is not adequate and it's greater than 120, then you call the doctor. Okay? You don't just not give it and don't do anything and let her contract. You want to call the doctor, because then he may want her, or she may want her, to get some magnesium sulfate. So we can give magnesium sulfate. Big thing with magnesium sulfate is it is a smooth muscle relaxer, just as the Breathine is. So smooth muscle lines the lungs, it lines the heart, it lines the uterus. Okay? When it relaxes it, okay, especially in the lungs, because we want to relax the uterine wall and the uterus with that smooth muscle, but unfortunately it does take a toll on the lungs as well. So we want to monitor that lung respiratory effort, respiratory rate, the quality of respirations. You definitely want to monitor strict I&O. Patient should be having 30 milliliters of urine every hour at least, and we use a urometer on the catheter. So a patient getting magnesium is going to have a catheter, a Foley catheter placed with a urometer. Okay, we want to make sure that they're excreting the drug because it can build up in the bloodstream and become toxic. On that same note, we're going to be doing the magnesium levels. So every 4 to 6 hours, we'll be drawing mag levels to make sure that they are not reaching that toxic level in the bloodstream. Another thing we want to check is DTRs, deep tendon reflexes, to make sure that mom is having reflexes, because again, when it relaxes that smooth muscle, the deep tendon reflexes will diminish. That's an indication of lung how lung expansion and issues with the lungs can occur. So we want to watch those deep tendon reflexes. So we want to have adequate output. We want to have adequate reflexes. We want to have magnesium levels, and of course, we're going to monitor the level of consciousness as well as the respiratory system altogether, the rate, the quality, the effort. All of that is really important. So we usually start it in grams an hour. We get a loading dose of the magnesium. It's usually a 4-gram loading dose. We load them up. They tend to get really, really hot with this drug because it tends to, when it relaxes and that smooth muscle relaxes, it can cause some flushing. And they get real hot, so that's not out of the norm. And then after that 4-gram loading dose runs in, usually it takes about 20-30 minutes for it to get in, then we put them at a maintenance level, which is like 2 grams an hour, 3 grams an hour, 1 gram an hour, whatever it needs to run at. So when we're assessing the patient on magnesium, this is where this question will come in. The client's receiving IV magnesium sulfate 2 grams an hour to stop premature labor. The nurse determines that the most important nursing assessment of this client includes what? INO, level of consciousness, and blood pressure, pulse, uterine activity, deep tendon reflexes, hourly urine output, and respiratory rate. INO, blood pressure, and reflexes. So looking at these 4, and some might have the right things in the choices, but they all have to be right, correct? So if you answer letter C, deep tendon reflexes, hourly urine output, and respiratory rate, that is what we're doing. That's what you're assessing for. So premature rupture of membranes, that's again when they break. The membranes will rupture on their own. Usually we don't break them prematurely. They will rupture on their own most of the time. They come in and we're looking for that ferning pattern. We use that nitrazine paper. We also want to make sure that the baby has an amniotic fluid index that's adequate around the baby. So that fluid volume around the baby should be adequate. You want to monitor this fetus, of course, and GBS status. So depending on how premature they are. So if they don't make it to 36 weeks, we probably don't know that GBS status, because remember, that's a test that's done 36 weeks gestation in the doctor's office. We may not know. So we may have to treat them prophylactically with antibiotics just in case, because with premature labor and premature delivery, there could be issues with infection. Induction of labor is to be considered depending on the lungs, if the baby's lung maturity is good. But I do know if they are ruptured, truly ruptured, we usually want to get them delivered within 24 hours because of infection. And of course, with all that infection, risk for infection, we want to monitor their temperature to make sure that they stay afebrile and they do not, get a fever, because that in itself can put that fetus at risk. And with infection, it's an indication of infection, but it also cooks that baby. We don't want that baby to stay with mom with that elevated temperature. A prolonged pregnancy is a pregnancy over 42 weeks. Well, we said, 40 weeks is usually the time, the week's gestation for the pregnancy. But like I said, it's not unlikely if mom goes a little past her due date, especially first-time babies, they tend to not want to come on time. But the problem is that placenta starts to age and break down. Those vessels start to calcify, or they start to disintegrate. They may not be adequately perfusing the oxygenated blood to the baby. So there's risk involved. And then again, if you let the baby go over 40 weeks, remember that baby's gaining weight constantly, especially toward the end. They start gaining like a half a pound a week. So if you let them go, and mom's pelvis is whatever size, if you're taking a risk with macrosomia. Macrosomia is a large baby, and that's a baby over 40 4,000 grams. 4,000 grams or bigger is considered macrosomia. And we have a lot of macrosomia with our diabetic moms because those babies get that sugar and they just gain all that weight. So the longer you let them go over the due date, the more chance for that weight gain on that baby, and then that baby can get too big, and then you put mom at risk for a C-section. So what do we do if she tends to go over, but yet we're not ready to take the, inducer or whatever? We can do fetal monitoring just to check fetal well-being, right? Remember that, fetal well-being. We can do a non-stress test on them to see if the baby's reactive. We could do a contraction stress test on them to see if the baby could withstand the labor or the biophysical profile, the BPP. We can check to make sure that the baby is adequately moving, the breathing movements are there, the NST is part of that, all that, looking for that fluid around the baby, all those things that we look for with the BPP, you could use to monitor if we're going to let this mom go over her due date. So those are just some things we can do if mom is, if the doctor chooses not to deliver her at 40 weeks. There's some complications of the intrapartum time, the intrapartum period. Malpresentation, failure to progress, operative vaginal delivery, C-section, meconium staining, umbilical cord prolapse. These are all high-risk things we're going to go into in depth in a few seconds, but you can refer to the table titled Alterations in Therapies for Intrapartum on page 2316 to 2319. Let's start with the first one, malpresentation. So malpresentation, this baby is not presenting in a normal way. So it is, it could be breech, it could be transverse, it could be a face presentation, depending on what is going on. So CPD, cephalopelvic disproportion or fetopelvic disproportion, where the fetus is too large to fit through the pelvis. It's frequently associated with labor dystocia, which is difficult labor. Okay, so if the baby is too big, it's just not going to fit through mom's pelvis. That could be an issue. Transverse lie, the fetus assumes a horizontal position in utero, so the baby is kind of laying side, or the head is more side to side, not so much. Remember, babies come looking down at the ground, the back of the head, under that pubic bone sliding down is the easiest, most, easiest way to deliver from below. So if the baby's head is turned to the side or the baby's more sideways in utero, it's called a transverse lie. Face presentation is when the baby is looking straight out and the face is the presenting part, or we call it the presentation is face, where the fetal face becomes that presenting part. We also call this a mentum presentation. Mentum is face presentation. And then, of course, breech. The presenting part is either the buttock, it's the buttocks, the feet. It could be one foot or it could be both feet. So footling breech, double footling breech, or frank breech is when they're butt first, like they're jackknifing out, kind of like that first picture at the top, where that baby's kind of jackknife in that jackknife position coming down the birth canal. Some operative vaginal birth instruments or use of instruments to facilitate and hasten the delivery of the infant when the vaginal birth is anticipated. So this can help get the baby down the birth canal. The first one is the vacuum extractor, and we usually say no more than 3 pop-offs. So the vacuum goes on to the baby. It's like a little suction cup, and the doctor will pump it up, and then with the contraction and mom's effort of pushing, it all has to work together, or like an orchestra, it all works together. Then the doctor will pull, and of course when you're pulling, sometimes the suction cup will pop off. You're only allowed 3 pop-offs with the vacuum extractor, because the more you keep doing it, the more of a chance of the baby forming a hematoma in the scalp, because it does suck, really hard on the scalp tissue. So that's a vacuum extractor. We see that used a lot, and they do use those as a matter of fact. They are used on C-section patients as well. We've seen those used in a C-section to help get that baby out. And then forceps is the other thing, or the salad spoons, we call them. And again, this is something that they put around the baby to help get the baby. We used to use them to deliver the baby, but then they've had a lot of neuro damage with the baby's head, having some even broken cranium bones and things happening. So they become very risky. We don't use them as much to pull the baby out, but we do use them maybe to rotate the baby to a OA, or a position that's more easiest to get the baby delivered vaginally. Just used to rotate, more or less, not so much to pull the baby out, because we used to use them to pull the baby out and it was horrible. But indications for these are to expedite delivery, to prevent fetal distress. So if you hear a baby in distress, you may want to kind of speed things up with these operative devices. Maternal exhaustion. She's so tired, her pushing is not as effective. So we may have to help her out with some of these things. She might have that really, really, really good epidural going. She's so numb she can't feel anything hardly. Now, they will feel pressure, but they usually don't feel the pain. So we have to tell them when to push, and we have to tell them when to hold their breath and bear down. So we may have to help them out with some of these devices as well. And then also, if they are tired, to decrease maternal exertion, we help them out with these devices as well. So again, here are the indications: fetal distress, maternal exhaustion, inability to push due to profound anesthesia, and also to decrease maternal exertion. So the C-section is the delivery of the infant through an abdominal incision. Usually it's a uterine incision. On the outside, you have the skin, and then on the inside it's a uterine incision. They can be different. So the uterine incision can be different from the skin incision on the outside, depending on the position that the baby's in, or how we're going to get this baby delivered, and the size. Skin incision types are phaneal or low transverse, or you can have a vertical incision into the uterine body, but it's still, again, in that lower area. Uterine incision types: low transverse over the uterus, or low vertical. Okay. The classical is a uterine incision that you might see, and you might see it on the skin as well. It's an incision made into the upper uterine segment, and usually it's done mainly in emergency cases. It's not used much anymore because, again, it's so risky that they can have a uterine rupture. So we try, when we see a patient, when I roll the covers back to go put her on a monitor and I see that, that classical incision on the skin, I'm like, okay, so what happened with that last pregnancy when the baby had to be delivered by C-section? Was it emergent? Yes, it was. They had to get the baby out quickly, and that's the easiest incision to make to get the baby out the quickest. Okay. Indications: fetal distress, maternal distress or compromise, so mama or baby in distress, abnormal placental implantation or an abruption. So if that placenta starts to tear off the wall of the uterus, it's called an abruption. And what happens is those vessels are busted and they're interfered with, so that oxygenated blood is not getting perfused properly to the baby. So the baby's going to go into distress very, very quickly. Cervical or vaginal abnormalities. So if the cervix is scarred to the point where it can't dilate or open, or the vagina has some abnormalities, they may have to do a C-section because that's not going to happen from below. Malpresentation, that's that breech baby, that mentum presentation, whatever's going on, the baby's not head down where it needs to be to come out the easiest, so we have to do a C-section. Cord prolapse, so that's when the cord slips down and it delivers, it tries to come before the baby. Okay. What happens is, when that happens, the cord gets compressed, and it's almost like you're cutting off the oxygen, because that presenting part, that head, or, is going to compress the cord because it's hanging out the vagina first. So if there's a cord prolapse, that's an emergent C-section. True CPD, cephalopelvic disproportion, if mom's pelvis is not adequate enough or shaped adequately to pass to deliver the baby from below. A prior classical or undocumented cesarean incision. So if they have a classical C-section with the first baby, remember we said that's not going to happen. You cannot have a vaginal birth after cesarean with a classical incision because they're sure to have a rupture in that uterine wall. If they have an STI like HIV or herpes, now I have seen patients deliver from below with HIV, herpes as well. The big thing with the herpes is if they're having a outbreak of lesions, they cannot deliver from below. That baby cannot get exposure to the lesions because they can get some issues from the herpes. They can have blindness. They can have other things happen from exposure. So if mom is not having an outbreak, she can deliver from below. But if she is in an outbreak situation, that baby has got to have the delivery via C-section. Meconium stain, we talked about that. That's when the baby has that bowel movement in utero. It's passage of fetal intestinal contents into the amniotic fluid. It can be green or brown colored amniotic fluid. It may have particulate depending on how, if it's chunks of meconium in there or if it's just like little particles. So again, this is, it could be a problem. We want to make sure that we have, I know at Tulane Lakeside we have to have a nurse practitioner or a pediatric team available to look below the vocal cords to make sure that the baby doesn't aspirate the meconium stained fluid into the lungs. They will do deep suction if they have to. They look again with that laryngoscope below those vocal cords. And also, we want to have adequate suction available on the delivery table for the physician. Usually, they will suction out very well as much as possible, and then hand the baby off to the nurse practitioner to check to make sure. So, if we have meconium stained fluid, as far as nursing interventions, we want to be prepared. For assessment of the fetal status and, calling the team that we might need present at the delivery. You could do an amnio infusion. Remember, we said that's when you put amniotic, we kind of put in, it's faux amniotic fluid because we're taking fluids and through the internal monitor, the IUPC, intrauterine pressure catheter, we're infusing fluid, a bag of fluid, to kind of flush out, I guess you could say, the meconium. So if it's thick pea soup consistency, it's easier to suction out thinner fluid than it is that thick pea soup. So even if we can't flush it out all the way, but if we can thin out the fluid and it's not as thick going into the baby's lungs, again, it's just easier to suction out if it's thinner. So we can do an amnio infusion through that IUPC, intrauterine pressure catheter, that internal monitor that we usually monitor the contractions with. It sits in the uterine, it leans against the uterine wall, and we can pump fluid through that to kind of, I guess you could say, dilute or, kind of make it thinner. Umbilical cord prolapse, that is descent of the umbilical cord into the birth canal ahead of the presenting part. So again, that's when that cord will slip down. Now, if a patient is not at zero station, and when I say the presenting part is not at the ischial spines, zero station, if that baby's in a negative plane and mom is dilated, she has to be dilated, baby in a negative plane, and the membrane's ruptured, that cord will slip right out. So it's contraindicated to get those mamas up walking around. They cannot get out of the bed and walk to the bathroom even. They have to stay in the bed. If their membranes are ruptured, the baby is not at zero station or below. They're above. So the baby's not yet, it's in that negative plane. That umbilical cord, and mom's dilated, that umbilical cord can slip right out. Okay. And when that happens, the cord becomes prolapsed. So there's compression of that cord. What kind of decels will you see? Cord compression, variable decels, right? Well, you'll see variable decels, and then when that baby completely is pooped out because it's not getting perfusion or oxygenated blood to them, giving them the oxygen that they need, then you'll see some seriously bad decelerations occur. But again, you just got to know that, if mom is not, at a zero station or a positive plane, then the baby is in that negative plane. There's lots of room for that cord to slip out. Symptoms would be a pulsating cord noted outside the vagina or noted in the vagina on a vaginal exam. Sometimes the patient has called out and said, hey, something just fell out the vagina. I don't think it's the baby, but I'm feeling something. You go in the room, you pull the covers back, you see this cord hanging out the vagina. So what do? The first intervention, maternal positioning. So if mom has an epidural, of course she cannot get on all fours, and we call that knee chest, where they can get on all fours because she can't move her legs. So we have to put her in Trendelenburg. We also want to get that presenting part off of the cord. So we will put our fingers in there and lift the head if it's the head sitting on the umbilical cord. And as soon as you do that, the baby's heart rate is perfectly fine again. Can you sit like that forever? Absolutely not. So we plan to do a C-section, and we get a C-section, set up for that. So maternal positioning. Now, if they, like I said, if they can get in knee chest, we can do that. That usually gets the baby's presenting part lifted up or elevated off of that umbilical cord. But it is always an urgent, not so much emergent. It could be emergent, but as soon as we find it, and you will hold that presenting part off of that umbilical cord until that baby's sectioned and that baby's removed outside the abdomen. So again, you will hold that presenting part up. It's very, it's difficult. You get under the drape until that baby's C-sectioned out. But we do what we have to do to get that baby out and get that baby stable. So, all right. Here's some positioning for umbilical cord prolapse. As you can see, mom's in knee chest. She's kind of on all fours with her butt up in the air. And that would be getting pressure off the umbilical cord. But if they can't get in that position, because of course if they have an epidural, that's not going to happen. The other picture is where the practitioner is holding the presenting part up over with a digital exam with fingers. They're pulling that presenting part up off of the umbilical cord because that's compressing the cord. Okay. Placenta previa is implantation of the placenta close or over the cervical os. Remember that placenta should move up as the pregnancy progresses, and that uterus grows and the uterine wall expands. That placenta actually slides up that uterine wall and usually sits at, like, I say 2 o'clock or in that upper corners. But if it doesn't move and it blocks that cervical os or that opening, there's different degrees. We call it placenta previa. It does show up as painless vaginal bleeding, so it's usually bright red. It's painless. They may have some vaginal bleeding or spotting. You can see that it's covering the os on an ultrasound exam. Mom may be on bed rest at the beginning of the pregnancy until that placenta starts to move up away from the cervix, but sometimes it doesn't, and they just have a placenta previa the whole pregnancy. One big thing, no vaginal exams. You do not stick fingers and rupture through somebody's placenta. So vaginal exams are contraindicated, and I'm always telling the residents, we can't do a vaginal exam on this patient. She's got a previa. So when you go in there with your fingers, you're going to bust open that placenta. So that is contraindicated. Lots of teaching as far as that with the patient as well. But it's painless vaginal bleeding that they might experience. We might tell them you might see bleeding and it's bright red, but if it's painful or painless is one thing we want to distinguish because it could be something else. But it's usually painless with a placenta previa. And of course, you want to monitor mama's hemodynamic status, especially if the bleeding is profuse, and monitor the fetus very closely for decelerations. Types of placenta previa, there's marginal, there's partial, and total. So as you can see, marginal is where the placenta barely extends to the cervical os. The placenta partially will cover the cervical os with a partial previa. And then the placenta will completely cover the cervical os if it's a total or complete placenta previa. Uterine rupture is when the uterus, remember we said if they don't have enough time in between contractions and there's hyperstimulation of the uterus, like if we're inducing them on oxytocin and we want to space those contractions, again, you don't want them to have hyperstimulation because it can cause a uterine rupture. And what happens is the wall will bust of the uterine wall. You could have a tearing of an old scar. Again, this is another reason why some doctors don't want to do a VBAC, because from the contractions and the force of the contractions, it could tear or cause a uterine rupture where there's a tearing of that old scar from that C-section. Fetal distress is some symptoms you'll see. That baby will go into fetal distress and you won't feel palpable contractions. Okay, so you want to monitor the maternal and fetal status. And then, of course, prepare the client for an emergency cesarean birth if they do have this uterine rupture. Placental abruption, it's when there's a tearing away of the placenta from the uterine wall and it's premature. So that uterine wall can pull off and cause some serious vaginal bleeding, intense abdominal pain because, it's very, very painful. The patient will have a hard board-like abdomen if you palpate. So what's happening is that uterus is contracting to hold on to that uterine, to that placental tissue that's tearing off the wall. So it's like one big contraction that never goes away. It's very painful for the patient. They have bleeding. It could be outright bleeding, vaginal bleeding. It could be concealed bleeding. They can be hemorrhaging inside. We just don't know sometimes, but it's intense abdominal pain, and that uterine or that wall of the uterus, or that abdomen, if you go to palpate it, it's very, very rock hard. It's like a board-like abdomen, very hard. And it's very painful. Sometimes they'll move your hands away from the abdomen because it's so painful. They don't want you touching their abdomen. So nursing interventions, management of hypovolemic shock. Again, if you don't see it outwardly happening, bleeding, they could have internal bleeding. Monitor the fetal status. What kind of decelerations will you see? You're going to see late. You're going to see late because there's a disruption of the placental vessels providing oxygenated perfused blood to the baby. So you will see late decelerations. This baby's going to have a uteroplacental issue. The uterus and the placenta are not communicating, okay, because that placenta is ripping off that uterine wall. So you want to set up again for an emergency cesarean delivery. Going back, let's just say, what are some things you think could cause an abruption? Well, if the baby has a short umbilical cord, it could pull that placenta off the wall. If mom does any kind of drugs, like especially crack cocaine or even cocaine, what happens is they have vasoconstriction. So anything that causes vasoconstriction can interfere and cause a placental abruption. A smoker. Again, any kind of vasoconstriction to the vessels of the placenta can cause it to have a abruption. Or if they have abdominal trauma. I mean, just think about it. When is a woman more at risk for spousal abuse or, abuse is when they're pregnant because, they're kind of helpless. They're defenseless. So the partner usually will take advantage of that situation, and that's when they really do experience a lot more abuse, and it's usually punched in the stomach, kicked in the stomach. It could be a motor vehicle accident where the steering wheel hits the stomach. So Any kind of trauma to the abdomen, and then of course some drugs, or it can happen on its own, depending on what's going on with the pregnancy. Shoulder dystocia. Well, that's when the shoulders are really, they have big babies that have these big shoulders, okay? And this is a delayed or difficult delivery of the anterior shoulder due to impingement of the symphysis pubis. Symptoms include delay in delivery of the head, regression of the head into the vagina. So they can, like, the head comes down through the vagina, and when mom is pushing, that head pops out. You can see that baby's head a little bit. And then as soon as the contraction's over, it kind of goes back in. We call it a turtle sign, or you can say turtling, where the baby looks like a little turtle with its head going in and out the shell. Okay? Because what happens is the shoulders get stuck. The head's down, but as soon as the contraction ends, the baby's head goes back in. And the shoulders are so broad, it's hard to deliver from below. So some nursing interventions assist with maneuvers to effectively deliver the infant. We may have to end up doing a C-section, but what we do is we can put them in a position called McRoberts maneuver, where we tell them to pull their knees back. I tell them, pull your knees back all the way to your ears, okay? And open, when they let their thighs open, it is the largest diameter of the pelvis that you could do in that position. So we want to give that baby the most adequate room we can possibly give them to get those shoulders delivered. So when you do McRoberts, it opens up the pelvis to the widest angle to facilitate those big shoulders to pass through. We can also do suprapubic pressure, where the practitioner will take their fist and right over that pubic bone kind of push down. Again, you don't want to break anybody's shoulders, or their clavicles actually is what's going to break if you do that. So we find that doing suprapubic pressure is the best intervention if you're going to try and help that baby come down. Never do fundal pressure. They used to jump on mom's abdomen at the top under the breastbone. Nurses would take their elbows and push down. That is a no-no. Studies have shown that will definitely cause some neuro damage, some Erb's palsy with the broken clavicle. Baby can have paralysis of the arm, where they're not moving the arms effectively because of nerve damage. So no fundal pressure, but suprapubic is okay. And that's, again, right above the pubic bone, having some pressure applied. Okay, and then, of course, that McRoberts maneuver is the most favorable position for shoulder dystocia. Okay, the nurse monitors a client during a vaginal delivery of a breech infant for which of the following is the greatest risk? What would be the greatest risk with a breech baby? Umbilical cord prolapse, intracranial hemorrhage, meconium aspiration, or fracture of the clavicle? So if you were to look at these, what is your best answer? Think about it. Say this baby's breech and the feet are down. What about umbilical cord prolapse being the correct answer? If you answered A, you were correct. Think about it. If the baby's breech, it may not be that big old head that's kind of sealing off that cervical area. So if it's just the feet, that baby still has some adequate room around the presenting part for that cord to slip down and prolapse. So if you answered A, that's correct. One more and then I'll let y'all go. Nurse determines that fetal distress is occurring after noting which of the following signs? Okay, which of the following signs? Moderate amount of bloody show, pink tinged amniotic fluid, meconium stained amniotic fluid, accelerations of fetal heart rate with each contraction. Okay, so fetal distress is occurring, or it might have occurred if you see meconium stained amniotic fluid. So if you answered letter C, that is the correct answer. You were correct. All right. Here are some videos on YouTube you can look up and watch of births, just in case you don't get to see one in your labor and delivery rotation, or you haven't gotten there yet and this test is coming up and that might be your last rotation. for the semester. So if you need to go back and refer to videos, they do have some deliveries, and I'm sure there's others you can find other than what I have here. But you know, it wouldn't be a bad idea to see a birth if you can, a vaginal birth. And that concludes this lecture. Labor 3. If you have, again, any questions or concerns, please feel free to contact me via email. We can set up an appointment if you need to meet with me. I'd be more than happy to answer any questions or any concerns you may have about the content. Have a great rest of your day, and I will see you next time. Thank you.